Hi, I'm Dr. Jeremy Smith. I work at the Hoag Orthopedic Institute as an orthopedic spine surgeon. I'm Chief of Spine Surgery and welcome you today. The topic I'm going to discuss are minimally invasive approaches to spine afflictions. We'll go over some of the basic pathology and symptoms and some of the basic conservative management strategies. We'll go over some of the minimally invasive options for both lumbar and cervical pathology. I'd like to welcome you to ask questions during the presentation. Certainly live we'll try to answer and give feedback. Certainly if I can't get to all of your questions, I'll make sure to answer in an email. We'll post on the website later on. So just to go over a little bit about a spine surgeon. So the traditional neurosurgeon versus orthopedic surgeon, I've been asked that question many times, and it really is kind of an old-fashioned question. The truth is that as long as your surgeon has dedicated fellowship training in spine, then we're kind of on the same level. I mean, the traditional thought of a neurosurgeon taking care of the nerves and the orthopedic surgeon taking care of the bones is very much of the past, and these days we all receive very similar training in both the musculoskeletal as well as the nervous systems, and really is what has advanced the field. It's paved the way for many more less invasive options. In the past, we think about large spine surgeries as being major surgeries that require longer hospital stays and multiple months of recovery. Minimally invasive options essentially offer a treatment and surgical treatment options for these same major pathologies as well as minor pathologies with minimal soft tissue disruption, which equates to less blood loss, minimal to no hospital stay, and a quicker recovery. So an example here, a tubular incision for a microdiscectomy you can be left with a very small incision. So the common diagnosis that you'll hear about in spine surgery, sciatica, lumbar stenosis, and cervical arthritis or stenosis, and scoliosis, and we'll go over some of the more modern, less invasive treatment options. Sciatica, we typically hear about pain, numbness, tingling. It's usually in a pattern when we think about kind of on the buttock and the back of the thigh radiating down. Oftentimes it's very difficult to sit. It's something that happens in acute onset. It can be a simple motion. It could be a sneeze or a cough. And it often afflicts patients in the younger age groups. Certainly it's something that is very disabling in some patients, and it's something that oftentimes I'll go into the office and a patient's standing up and unable to sit down in such severe disabling pain, and it does warrant attention. The common workup in the office, we generally will perform an X-ray, and an MRI is considered the gold standard. What we generally see in these situations is the intervertebral disc. The disc is the cushion between each of the bones, and you can liken it, and the analogy I make is like it's like a jelly donut. There's a hard outer crust and jelly inside, and what happens is you can have a hole in that hard outer crust, and a piece of that jelly essentially is squirted out and is pressing on the nerve. It generally happens at the low end of the lumbar spine. Usually there's 5 lumbar vertebrae, and it happens between the 4 and the 5, or the L5 and the S1 being the sacrum. It's something that in severe forms, if it's causing weakness, if it's causing bladder and bowel functional changes, if it's that debilitating, it can be an emergency. So in those situations, emergency attention needs to be sought. But oftentimes these are situations where it does require urgent attention, and some of the management strategies that we use I'll go over. Generally, and if we look at the statistics, 75% of the time they heal on their own. Really, time is your biggest friend. Your body essentially can heal itself. Believe it or not, that piece of jelly that squirts out and is pressing on the nerve, your body sees that as something where it's not supposed to be and can essentially attack that, almost like an infection. And so as a result of that, of your immune response and that inflammation, it creates more pain. Therefore, a lot of the treatments are centered around anti-inflammatory medications, ice, anything to reduce inflammation. So that conservative course often involves NSAIDs, so ibuprofen, Advil, Aleve. Sometimes we do a short course of oral steroids. You've heard of epidural steroid injections as well, and we'll attempt sometimes a series of epidural steroid injections. This, along with physical therapy, can often take care of the problem. And again, within 3 months, a lot of times a surgery is not needed. If it is needed, this is one kind of the mainstay and one of the first micro surgeries or minimally invasive surgeries that we've been able to provide for our patients. It often involves a 2 centimeter incision, and we can use tubular retractors essentially to limit the tissue disruption and really focally see where that disc is. And what we do is essentially use our instruments and microscopes to see that disc and shave down any pressure on the nerve. And on the picture on the left there is what the disc looks like when we remove it. And you can see the postoperative incision. It's very small and heals very quickly. This is an outpatient procedure with minimal blood loss, and recovery is very quick. So the pros of doing less invasive surgery is really the surgical time, the smaller incision. There's less soft tissue disruption in these situations. In approaches, we're able to use specific planes between muscles that limits the amount of permanent damage that can happen in an otherwise open and invasive surgery. So postoperatively, patients generally require fewer narcotic medications and can return to normal function, and long-term really have no damage to that muscle that otherwise would be damaged in the larger approaches. One of the more recent advances that we're seeing more commonplace, and it's something that's not widespread, but there are some surgeons that are versed in this technique, is the endoscopic spine surgery. And it's something that will work for a very limited population of patients and pathologies, and certainly in these situations, I'd be very selective in your surgeon, in particular in their experience, because it is rare and there is the potential to cause more harm than good. So this is something more of a warning. If we were to consider an endoscopic procedure, I certainly would want to know what the alternative would be. That's a more traditional, either minimally invasive or more open surgery. Moving on to lumbar spinal stenosis, and it's a very common diagnosis that tends to afflict patients that are older, and generally in their 50s to 70s. And generally the stenosis is essentially less room for the spinal nerve root. So when we talk about stenosis, this is the general area, so less room for the nerves, and it can be caused by a number of factors I'll get into in a moment. But the symptoms associated with stenosis can range from back discomfort that radiates to the buttock. Generally, it creates more symptoms in the standing and walking position. It very much is mechanical in that in the standing position, there's more pressure on those nerves, and then the leaning forward or sitting position, that pressure is relieved. So patients feel more symptoms when they're standing and walking. Oftentimes, I'll ask if the symptoms are relieved if you're going to the grocery store and leaning on a shopping cart. Oftentimes there's a vague discomfort or heaviness to the legs that does improve with position, and that's very important in describing how patients will respond to surgery. So generally it can be caused by multiple factors. If we look at the discs themselves as they degenerate and become herniated or sometimes even calcified, sometimes the vertebra can slip relative to each other and become unstable. The joints in the back of the spine can become arthritic and actually enlarge, contributing to the stenosis as well. Sometimes cysts can come off of the joints and create stenosis. It's something that's very much a mechanical symptom and mechanical result that oftentimes is not treated very well with a conservative modality. We still try basic conservative strategies such as physical therapy, anti-inflammatory medications, epidural steroid injections as well. Oftentimes, unfortunately, the success rate is only approximately 30%. So it is something that can be disabling, and certainly jumping into an operation, even knowing these statistics, we sometimes really look at the degree of the stenosis, how bad it is, and realistically how invasive a surgery would be, and make the decision whether to continue a conservative course versus surgery. So in the treatment of for stenosis is a wide array of treatments. For the most, probably the typical historical screws and rod technique for arthrodesis or fusion is still very commonly used. The way we perform the surgery is less invasive. We can use some of those minimally invasive and muscle sparing techniques to limit the amount of damage that happens, and certainly the blood loss and hospital stay. But there are a lot of treatment options that have been successful and not so successful. Well, there's one that I wanted to discuss with you a little bit further that I've seen more success in my practice and has become more popular. It's a stability device, whereas the typical surgery to decompress the nerve roots does not allow for a stability factor, and it doesn't help with decompressing the nerve tunnels. In an interlaminar stabilization, and this example is a Coflex, we're actually able to decompress directly the nerve pressure caused by disc herniations, by joint arthritis, and by cystic changes. We can actually place the device that will provide stability to a level and allow for distraction to hold a nerve tunnel open. This is kind of a balance between a typical simple decompression and a fusion, which is certainly more invasive but does provide the best of both worlds. Shorter operative times, less dissection, less blood loss, smaller incisions, shorter hospital stays, and we're seeing results that are equivalent to the typical laminectomy and fusion of past. Again, this really is dependent on your diagnosis, your pathology, and it really depends on whether your surgeon has experience and whether or not your pathology fits the mold of what, whether or not this would be successful in your case. Moving on to cervical procedures or cervical arthritis, so certainly we hear about the same type of idea of disc herniations. Arthritis can similarly cause problems in the cervical spine. The symptoms that patients generally present with include arm pain, numbness, tingling, and weakness. Certainly the difference between the lumbar spine and the cervical spine is that the spinal cord is present. The spinal cord actually ends before the lumbar spine. So when we're dealing with the cervical pathology, if there's any pressure that's on the spinal cord, particularly if it's severe or causing damage to the spinal cord, it's something that we need to know because it oftentimes needs to be addressed with surgery, and the conservative approaches are less available. Some of the more important and worrisome symptoms associated with cervical stenosis or cervical disease, if there's coordination issues and problems with fine finger coordination, problems with dexterity, problems with things like buttoning up buttons, turning keys, twisting jars, handwriting changes, heaviness, can even affect your balance and gait. So all of these associated with a neck pain or progressive onset neck symptom can be somewhat worrisome and requires further workup. So typically the non-operative course, if it is something that is not having some of those more dire symptoms, if there's a primarily pain, numbness, we often choose a non-operative course, and we'll try a course of physical therapy, epidural shots, and anti-inflammatory medications. But oftentimes surgery can be indicated, and the typical surgeries that are considered the gold standard that you've probably heard about, the anterior cervical fusion or anterior ACDF, anterior cervical discectomy and fusion, is considered the gold standard. It is a very good surgery. It is one of our best surgeries that we have. It's something that the approach itself, even from the beginning, is considered a less invasive surgery. The incision is something that there really is no muscle cutting. We have a special retractor system that protects all the important structures in your neck. We're able to address the pathology, see it directly, and reconstruct the spine very elegantly. It's something that there are problems associated with it, particularly because it's a fusion, because we limit the mobility of a segment. That can change the mechanics of how your spine moves and how it affects the level above or below. So it can actually increase the stress and create this so-called domino or adjacent level disease. And so that is a problem that we commonly see. Sometimes if pathology is extensive and spanning multiple levels and not just at the disc level, it's something that is approached better through a posterior surgery. A posterior or back of the neck surgery is a much more invasive approach. It involves shaving the muscles off the bone, and the muscles in the back of our neck's pretty extensive, so the healing does become a little bit longer. The complication rates are a little bit higher, and that blood loss, hospital stay, all of the above become a little bit more complicated. We can address simple pathology sometime through micro incisions in the back of the neck, but those pathologies are a little bit rarer and require a surgeon who's savvy with addressing these minimally invasive posterior surgeries. One of the more recent developments in minimally invasive cervical surgery is a motion preservation device or a disc replacement. So the idea is to be able to address pathology directly as we would through an anterior cervical fusion, but at the same time, instead of fusing those segments, we're able to preserve motion and thus the mechanics of the rest of the cervical spine. That does prevent or help inhibit the adjacent level from deteriorating as a result of those mechanical changes. It has become more commonplace and accepted as a good alternative to fusion, but it also depends on the level of arthritis, whether or not there's a deformity present, and certainly those are dictated by the patient's imaging studies and specific pathology. But it's worth asking your surgeon. There's many different devices. These are three of the devices that I've traditionally used that I've found to be very effective. And it's one that, again, your surgeon has to be well versed in the technique of that specific device. Laminaplasty it's a posterior surgery in the cervical spine, which still does require some of the dissection. It's a little less aggressive, but it does address a wider spread problem. It was developed in Asian countries because of a high incidence of what's called ossification of the posterior longitudinal ligament. It's a fancy term for essentially saying there was a calcified area in the front of the spine that impinged the spinal cord, and as a result, this helps. It's a less invasive technique to preserve motion but create more room in the spinal cord. So when the stenosis is diffuse and there's a lot of pressure, we're able to create essentially a wider spinal canal and lessen the pressure on the spinal cord, thus alleviating some of these major neurologic issues. So it is, we indicate when we want to consider a motion preservation device when it's more of a diffuse stenosis, but there is less blood loss and a quicker recovery. The last topic I'd like to talk about is scoliosis. Certainly we hear about the typical adolescent scoliosis. It's a more inherited problem, and it's something that doesn't necessarily in itself cause pain. We think about adult degenerative and a lot of the adult surgical indicated scoliosis. We think about scoliosis caused by the asymmetry of the arthritis in the disc. So when the disc collapses asymmetrically more on one side than the other, that will inherently create a curvature. So when we're looking at methods to reconstruct the spine, it involves removing that asymmetric disc and replacing it with a spacer. The typical technique that you've probably heard about is going through an anterior or front approach, or an incision generally on the belly is a little bit more invasive and does involve more hospital stay and is more of an aggressive surgery. Some of the newer techniques, and it's called a lateral. One of the trade names is the XLIF. It's an approach that's on the side, and that incision is less invasive. There's really no muscle cutting, and we can use a small tubular retractor to really remove the disc and reconstruct the spine pretty elegantly. There's minimal blood loss, and sometimes if we do these surgeries in a standalone or limited fashion, can be an outpatient or very limited stay. So we're doing those very regularly now with great success. This is how the approach looks when a patient's positioned on the side, and we can actually really bluntly find our way without doing really any cutting, and through a small incision and using our navigation, we can achieve what we did in the past with a much larger incision and major reconstruction. So this is just going through some of the images that we see intraoperatively, and just fascinating to see what we can do through a very small portal in some of our imaging guidance technique. And we're able to really restore major deformities through simple approaches because of this procedure. So just some examples of a correction of major deformities through these techniques that often involve open versus percutaneous screw fixation. However, adding this technique makes a usually very invasive surgery. It cuts down on the invasiveness and it allows us to do a little bit more. Some of the newer techniques are combining both the side or lateral procedures and the posterior or back procedures. We're able to achieve both a side position surgery and back surgery in one sitting, where we don't have to reposition the patient. It's less operative time. They still have the less invasive qualities, and certainly it lessens the hospital stay and perioperative problems. We always have to be careful with the latest and greatest, and I'll leave you with just kind of a warning, just because we hear some of these newer techniques, and we always have to be, question certainly how long they've been used, what success, what has the surgeon's success rate has been, what does the literature show. These are just some examples that we tend to use a little bit less, and it's certainly something that it's worth getting an opinion from your surgeon, and honestly, a lot of times a second opinion regarding it, to see if you're getting the same opinion regarding a specific pathology. So I have some questions. If someone has a lumbar stenosis, can the stenosis move up to the cervical spine over time? It's a great question. A lot of times what we see is some of the pathology, what causes the stenosis, and inherently within the discs themselves, if there's a degenerative quality, a lot of times there's a genetic predisposition to having those discs break down. And sometimes even the joints, there's this genetic predisposition. So it's not so much that the stenosis in the lumbar spreads to the cervical, it's just the anatomy and the pathology that exists in the lumbar. Also, that's the same genetic makeup in the discs in the cervical spine. So what predisposes the lumbar or the cervical to that change is really the same. So unfortunately, we do see some patients who have had a lumbar surgery also need a cervical surgery. That's one factor. Sometimes it's really the space available for the neurologic structures. So lumbar stenosis, or something called congenital stenosis, essentially there is just less room to begin with. So much, and you might have MRI reports that says you have a 2 or 3 millimeter disc bulge or 5 millimeter disc bulge. And I always have a problem with that, because it's not so much the size of the disc bulge, it's really how much room that your nerves or spinal cord have. So great question. I do think that this is, unfortunately, patients who have stenosis in their lumbar and cervical, it's more of a genetic predisposition.
I'm going to ask you this.
Sure.
You repeat it because it's very long.
Sure.
My symptoms are extreme pain in the calf, but only minimal lower back pain.
Sure.
At L4, L5, S1 area. Is this sciatica or lumbar stenosis? Does the MRI conclusion diagnose what I have?
So sciatica is a clinical symptom, and stenosis is a radiographic finding or an anatomic finding. So you can have stenosis, which is what we see on the MRI or X-ray, but the symptom of sciatica is more of the radiating pain. So kind of one and the same. There's a lot of overlap there, but to answer your question, to me, it sounds like if there's severe pain in the calf, particularly if it's in the sitting position, that's generally more of a sciatica. If it's an aching, throbbing pain, that's more when you're standing and walking and it's more diffuse, that's more of a stenosis. The clinical term is neurogenic claudication. So my answer to you, it's probably sciatica, very commonly, most commonly from the 4 or 5 level. And one common question is, well, if I don't have back pain and I just have leg pain, is that even possible? And I'd say yes, very much so. In fact, those patients generally respond better to epidural steroid injections and surgery. Back pain is always difficult to treat, very difficult, to treat and guarantee relief with surgery. So what is the success rate for spinal fusion? And so loaded, very, very question that covers a lot. I think that's a very difficult question to answer briefly. It depends on the situation, it depends on the location, depends on bone quality, depends on the degree of deformity. Generally speaking, so if there's a single level disc that when we perform, a surgery that removes the discs and we put a spacer back in, there's so many different approaches. But if I were to take, say, for example, a degenerative L5-S1 disc and the standard, and Tiger Woods is an example, he had an anterior lumbar fusion, an incision from the front, removing the disc in a small graft with a plate and screws. The success rate of that bone fusing is very high. I mean, it will fuse over 90% of the time. Now, that doesn't necessarily define success. So, the success in treating leg symptoms is generally very good. The success in treating back symptoms is very questionable. Some of the quoted literature says approximately only 60% of patients receive, it's only 60% successful treating back pain. And that's partially successful, but partially true. It very much depends on the individual, the pathology, the approach, the symptoms the patient is having. It's a discussion that you need to have with your surgeon, and I think it's something that if you don't have the ability to sit down and really have this defined, then you probably should see someone else. It's not as simple as, say, a hip or knee replacement where it's an arthritic joint, we fix it, that's it. And there's so many different approaches, minimally invasive, maximally invasive, and so many different pathologies that has to be defined. I'd like to think in my hands the success rate's very high, and I wouldn't do it unless it was going to be considered, above 80% successful. But again, it depends on the situation, and if it's anything less than that, then that should be defined and considered preoperatively, where you're having that discussion of that potential risk. Sometimes there are many options. We know that it's not going to give 100% relief, but it will at least give enough relief to get a quality of life back that's been lost and no other measure is working. We'll go one more question, then I can answer any other questions. What are the restrictions in recovery after spinal fusion? So after a lumbar fusion, we try to get you moving right away. So the same day of surgery, you're up and you're moving. I generally limit the BLTs, bending, lifting, and twisting, for the first 6 weeks. I don't want you lifting anything heavier than about 15 pounds. And so I encourage a lot of walking. A brace is really for comfort and to help keep your position and posture in order. I find it helpful in patients who maybe are feeling too good and want to try doing things they shouldn't do, but a brace is not really holding anything in place. It really is more restricting your position and helping improve your posture. Posture habits are very important, not just in the immediate post-op recovery, but long-term. Looking at your posture habits and being in a sitting position. A lot of us have desk jobs and are sitting at a desk for many hours during the day. So looking at what you are doing is very important. And in the beginning, Post-operatively, I like you really to focus on those habits, and certainly changing them long-term can limit some of the problems that can develop at other levels. Any other questions? I think we're just about good. If you have other questions, please don't hesitate to jot them down. I'm at the Orthopedic Specialty Institute, and you can find us at the Hoag Orthopedic Institute website. I'm happy to see you in consultation. I'm in the Irvine office and Orange office. But thank you for your time, and have a great night.